2 weeks ago, the CDC came out with the most current data set of obesity and overweight in America, and we're not flattening this curve. It was 42% of Americans are now obese, and I believe in 1960 that was about 5%.
Hello and welcome to Healthy Living. I'm Dr. Donald Pelto, and I have today Dr. Mark Cucuzzella here. He's a family physician, and welcome to the show.
Well, great to be on, Don, and a pleasure to connect with someone in the allied health world. I think what we're all doing as a team is how to get people healthier, across the medical channels.
Yeah, and you've done a lot of work with both running and with nutrition and overall health over the last years in your whole career. And what's been inspiring, we're going to talk a little bit off of podiatry. We're going to talk a little bit more about the health issues, if that's okay with you today.
Oh, yeah. And I think it all links back to podiatry. So if people are healthy, you don't need to do lower extremity amputations for diabetes, and they won't get neuropathy, and they won't have Charcot feet.
So all of that. So let's go into it. So let's talk about nutrition. As a physician, how much nutrition information and that did you receive in school, and how did you learn about this new approach that you've been recommending, and how long have you been recommending it?
Gosh, in medical school, probably zero or like negative, kind of going into the negative, because what we really learned was nutritional hypotheses in the day, without everyone had a hypothesis about nutrition. And when I'm 54, so I graduated med school in 92. And back then that was right in the middle of the diet heart hypothesis, meaning, you eat fat and carbohydrate, it turns to blood fat and carbohydrate, and therefore your arteries get clogged. And that created the first food guide pyramid. That was in the 90s, the first food pyramid, but the dietary guidelines for America first came out in 1980, which suggested to the population of our country, Don, to reduce fat and eat more carbohydrate. But we all kind of bought into that as conventional wisdom. And, I told many patients for years, well, of course, to lose weight, you have to eat less and exercise more.
Yep.
And it kind of worked for me. I didn't count calories, but I was a runner. So I think the hypotheses were all driven by the skinny people, meaning, well, I can burn my calories and eat my calories, and therefore you should be able to do the same. I don't think any of us meant harm by saying that. We just didn't know the science.
Yeah.
But I think we've come a long way. We're relearning the old science, basically. This is not new material. This is how we treated obesity and diabetes before, that diet heart hypothesis and the food guide pyramids, which we're slowly backing out of that room now.
And so how long in your practice have you been advocating this dietary approach, which I think is probably, I'm guessing it's low carb and intermittent fasting, or one or the other?
Well, they all kind of, I try to treat insulin resistance, and they both are levers into treating insulin resistance and hyperinsulinemia, which is kind of the full catastrophe we see right now. So if you look at just, I think 2 weeks ago, the CDC came out with the most current data set of obesity and overweight in America, and we're not flattening this curve. It was 42% of Americans are now obese, and I believe in 1960 that was about 5%. So that's like, a skateboard ramp. That is just astronomic change.
Mm-hmm.
And overweight is about 74%. And so right there, you've got, 3/4 of the population, which are metabolically unwell. And now you have this other subgroup too. That's just based on BMI, Don. But there's these other folks called the skinny fat, right? You may even have some in your clinic, they're sarcopenic. Maybe they've even had a lower extremity amputation, right? So they have a low BMI, but they're fully diabetic and fully metabolic syndrome. So if you take that group and add them to the former group, the UNC did a large database a couple years ago, which showed only about 12% of our population in this country is metabolically well. And that's a sad statistic.
Wow.
So they don't come into your office or my office, but maybe once a month, I'll actually see someone who's kind of a well person, wow, you're 70 and you're not on any medicines, why are you here? So that used to be the norm. And now that's, the unusual exception. Most people my age, I'm 54, are on 5 prescription medications.
Now, Mark, so let's talk the 80% that you see every day. How do you incorporate this in with your normal patient base? Like, are you an evangelist and telling everyone about this? Like, how do you have time in your 10-minute slots with them? How do you do this?
Yeah, it's hard. I've written patient books, so so instead of explaining it to every patient, I've got a number of things that I'll give to them to read. And fortunately, they've opened a clinic here at West Virginia University, which 3 years ago this was kind of rogue. They opened a clinic which allows me to teach low carbohydrate and diabetes remission, not treatment, remission. I mean, we treat diabetes, but our goal is remission. And so I get an hour with a new patient and we go over. So yeah, so it's great because you really get to dissect it. We can prescribe a continuous glucose monitor, teach them how to use it, and kind of set up some of the remote patient monitoring with Freestyle Libre link. So, you can really you got to kind of own it with them. They have to own it, but they need someone to, not just a quick 15-minute visit. If these people are horribly sick, which many of them are on multiple medications, they need to kind of get a deep understanding of why they're there and what the first thing that they're going to change in their life is. Some people are like all in, jump right into the cold water. Other people need stress is high in their life. They haven't treated their sleep apnea yet. They're on night shift work. They've got food pushers in their house. They're carb addicted, so we got to sort out for them, what the big rocks are that are in their way, that are kind of the landmines.
Wow.
But that's not all. I mean, I'll also do this in 15-minute, primary care visits, just introduce them to it, give them something to read,
and then
try
see back in 3 months,
come back in a month or a few weeks.
Wow. And so what a privilege to have an hour or even a group of people that you can spend.
Yeah, we do group visits, which got shut down. They were the most fun. Once a month, actually, no, 2 times a month, we were doing group visits, group medical visits. We'd sit around a table without masks. Wow, it seems like so long ago, and we'd laugh about things, and talk. But I hope we do some Zoom community group meetings now. We have a low carb network, so that's a substitute just to give people that sense of community.
And there's something, and this is for kind of the lay audience, this interview, do you do something called motivational interviewing to kind of determine who's ready to make those changes, or do you just kind of blurt it on everyone?
Oh, I listen more than I speak. I think the term motivation is kind of misconstrued because, this isn't like willpower, where you can just, finish the marathon at no matter what cost and inflict pain in your body. That's a limited resource. So I think if I can teach them to understand their metabolism, and then they actually feel good and have energy. So I try to, enable them, encourage them to do something for 2 weeks. That's the opposite of what they've done their whole life, which has likely gotten them to why they're in the office right then. This isn't working for you.
Yeah. Let's try something for 2 weeks.
I'm going to support you to do something different for 2 weeks. Now, if it's not working for you, that's fine. But let's try, are you committed to do something for 2 weeks? What do you need to do to prepare?
So small little gains.
Yeah. And just try it for a couple of weeks and see how it goes. And if they fall off after a few days, get back on. It's cool,
And then do you see them are you have the privilege of seeing people every 2 weeks, or do you see them every 3 months? I
usually will see a new patient back depending on how ill they are. Like if it's someone on multiple medications, insulins, 3 diabetes medications, 4 high blood pressure medications, I'll usually see them back in about a month. Mm-hmm. Just, and then I give people my text, so if we're reducing medications down, they need to be in daily contact, with me. And I have an app on my phone so I can follow patients. This is the most beautiful thing. So I have a continuous glucose monitor on my arm now, but every patient I have who has one,
you're connected to them.
I'm connected to them. These are patients that, I could tell you a story about each one of these. Most of them started with A1Cs of 13 range.
Now, I was thinking about this because I was watching your recent thing about glucose, doing the little swipe thingy. How can I give these to my patient?
Yeah.
No, I can't. I'm a podiatrist.
Yeah, you can prescribe, correct? You can prescribe a medication at a pharmacy, correct?
Yeah.
Yeah. So you could prescribe.
Do you have to have diabetes? Do you have to have diabetes?
No. So to get it covered by insurance, you need a diagnosis.
Okay.
But they're about $60. So this little sensor here on my arm, this coupon's available, GoodRx. They're $60 for 2 weeks.
Okay.
And you can
Wow.
scan it as much as you want. So I think anyone who uses it for 2 to 4 weeks will see exactly what's going on.
I didn't know I could do that. I'm gonna
Yeah,
prescribe one
try
for
it
myself
yourself
and
just
try
to
it for
learn the
myself.
technology.
Thank you.
And you learn your own patterns too. So, I mean, this is just how it works. So this is today. So I have a form, I learned this because I developed a form of diabetes in 2012 called latent autoimmune diabetes of adulthood, meaning I don't make insulin. I make just a hair to not need to inject if I keep my carbs at about 20 grams a day. Otherwise, my sugars are high, and I'm right on the edge. Each year, my pancreas might decide at a certain point I've lost that little. It's called a C-peptide. So this morning, I woke up, and in the morning your sugars go up. This is without eating. And I went for a run. So my sugars actually usually will go up to the 150 range, no food, right? But that's because of my issue, and that's maybe sometime a little. So that's not optimal. And ultimately, I might need a little bit of insulin. But then as soon as I have breakfast, I had a 3-egg omelet. It comes right down to 107.
Okay. Wow.
After the meal. And then the rest, my highest, and here's the rest of my morning, right? It's, it's pretty flat line, around 110 range and stable. Now, for someone with a diabetes condition, sometimes you can't be perfect, but what you shoot for is this complete stability in your blood sugar. It's these highs and lows, which are injurious to our blood vessels, small and large blood vessels. So, but you got to know, like, if for some reason in 3 months, I'm not eating carbs and my sugars are just creeping up higher and higher, I'll probably need to add a low dose insulin. And that's okay. That's cool. That's what it is. I'm a healthy person. It just doesn't make insulin. But I'm monitoring this, and this approach kept me in the Air Force, because if you're declared diabetes full, you're boarded. So if you can keep it under wraps with your own lifestyle, you're basically not diabetic yet. So I'm technically pre-diabetic, but I'm not fully diabetic.
And with the low carb.
Yeah. Now, if I ate the way everyone else eats, I'd be fully diabetic on medications, uninsurable by life insurance, by health insurance. It's a mess, right? There's a lot of downstream. Plus, I wouldn't feel good. I mean, I feel good now.
Yeah.
This isn't it's not a sacrifice to eat well, to keep my sugars controlled.
Well,
I feel good.
That's what I want to talk about, Mark. If a patient's been eating their whole, like, let's say they're 60 years old, they've been eating the way they've been eating for 60 years, and they come in to see you, and you talk about, I really liked your analogy of levers. So explain to me that analogy. Let's say you've already explained about insulin resistance and insulin, and you say, well, there's 2 levers. There's low carb, and then there's fasting. How do you explain that? And then how do you teach them to eat low carb?
Yeah, so we're really fighting insulin resistance and high insulin levels. That's obesity and type 2. So we can talk about what drives hyperinsulinemia, meaning pancreatic production of insulin in a body that is resistant, meaning I can't stuff any more glucose into my liver and muscles, right? The house is full. Can't stuff any more shirts in the suitcase. I've got 1 teaspoon of sugar in my bloodstream. If I'm 100 milligrams per deciliter, we have 5 liters of plasma volume. So if you do that cancellation math, the body's bloodstream has 1 teaspoon, 5 grams of sugar, carbohydrate. That's like nothing, right? Like a 12-ounce juice has 10 teaspoons of sugar. So as soon as your body has developed insulin resistance, the system is full, 10 teaspoons of sugar in the bloodstream, pancreas starts cranking insulin out. It used to just knock on the door. Young runners, right? They can have pizza, right? Insulin up, knock on the door, store the carbohydrate, run tomorrow. The insulin resistant person, no, can't store the carbohydrate. Instead of knocking on the door, it starts pounding on the door. Right. So that's hyperinsulinemia. So the hyperinsulinemia can be immediately reversed by not stimulating insulin. So that's like a low carb, no carb diet.
And how do you teach someone that's been eating the same way 60 years? What do you say, Mrs. Jones, look at this website, or nutritionist?
Yeah, so I'll explain that basic insulin resistance to them, just so they kind of get it, right? So the food is a tool, but if they understand why, and the resistance comes from other things. So exercise is wonderful to decrease the resistance. So that's the other lever. Sleep, they all got sleep apnea, right? So stress, right? So you got to decrease the insulin and decrease the resistance. Work on all of that, but figure out in their life what's the biggest lever that you can. Most people, it's the food, because that's the most dramatic one.
Yep.
Then go for a walk. They don't need to go to the gym, which are closed now, but go for a walk. But if they understand that, the basics of that, and they understand what a teaspoon of sugar is, like they need to understand the power of a teaspoon of sugar, because that's all in the bloodstream.
Yeah, I like that.
I just have some basic food lists. It comes from Tim Noakes. I've been using it since 2012. In Real Meal Revolution, he has green, orange, red list. Green list, eat to satiety. Meat, eggs, cheese, seafood, leafy greens, non-starchy vegetables. Those are the safe foods, very low carbohydrate. I can eat that stuff all day, pretty flat. Anyone who's got diabetes, all they have to do is try it. I'm going to have a big ribeye tonight. It's probably a pound. That will not touch my blood sugar.
Okay.
If I had a piece of fruit on the side, my sugar would be 200. The ribeye is not the problem. I'm not trying to lose weight. The ribeye is not, I'm trying to stabilize my blood sugar.
Blood sugar.
Yeah. So, and then they become their own experiment. I've seen people be able to tolerate a banana with diabetes. That's rare because a banana has 6 teaspoons of sugar. But they think, well, I need potassium. So again, your question on the fasting. So I don't really kind of go there first, because when people go to low carbohydrate diets, which are rich in fat, protein is massively satiating. It's the most satiating macronutrient. Just imagine, like right now, you're going to go eat tuna fish. Like, how much could you eat? It's like, yeah, like at a certain point, I'm done, right? Or
same
eggs,
with steak, ribeye.
Yeah, you're done. So once they are allowing their body to access their body fat as a fuel source, which comes from low insulin state, insulin has to be low enough to be able to mobilize body fat. If you kind of half do it, it won't work, because insulin is still up and it's storing. So once people get that insulin down and they start having energy, then they spontaneously aren't hungry. So then they might, like at the next visit, are you hungry in the morning? No. But if they're still not wanting to maybe, escalate the weight loss a little bit, why don't you try having breakfast a little later, and after dinner, don't snack. So you don't bring that on to people right on, because they have to teach their body to use fat as fuel first. The first goal is not to lose weight. The first goal is to access the big tank, which is the fat, which when you're high insulin state, you can't access it. It's locked in. Insulin locks that in. Then they have no energy, because it's like you're pulling around a big tank of petrol, and you got a little 80-gallon diesel tank in your truck. And Steve Finney, that's his analogy, but it's perfect, right? You got this big 10,000 gallons of petrol, it's the tanker truck on the highway, and you've run out of gas. You're like, WTF, you got all this here. So insulin is putting it into the tank, and you can't get at it. So you got to, and they're like, oh yeah, I draw it on a little whiteboard on a clipboard. So if you can't explain it to people, like on the back of a napkin,
it's too complex.
Explain the metabolic syndrome to them, and then they're, oh yeah, I have all 5 of those things. I've got waist circumference, low HDL, high triglyceride, high blood pressure, high sugar. Oh yeah, I got them all. And they treat them all with meds, but how about we get the root?
Yeah, great.
The root of the metabolic syndrome is hyperinsulinemia. So, oh yeah, let's not treat the branches of the weed. Let's treat. So you just kind of have a nice conversation and exonerate them of any shame or guilt that the reason they are obese is their own lack of motivation or willpower. It's not their fault. Like, they've been shamed. There's a bias. The medical system biases them implicitly and explicitly. So get that off the table first. Look, I understand this is not your fault. I know you're not gluttonous and lazy, right? I know the world's been telling you that. And they'll even, like, if people will cry because they know they're not gluttonous and lazy. Right? They've starved themselves multiple times.
It didn't work.
And it's like, look, I get it. You don't need to tell me that. I understand. That's why you're here. And then you can have an honest conversation, because you have empathy for them.
That's great. Well, this has been great. Everyone, this is Mark Cucuzzella. If they want to learn more, you have the Simple Food Rules. That's on your website. What's the best way they can learn more?
I'll send with, I've made a little patient guide
Okay.
And I can send it to a link, but it's, if you go to tinyurl.com
Yep.
/ low carb any budget.
Okay.
tinyurl.com / low LOW carb any budget. And what that is, it's like a little 50-page ebook with recipes at the end, simple. It's designed to be able to go to a dollar store where
Perfect.
most of my patients
Our
go.
patients eat. Yeah.
Yeah, like West Virginia is one big food desert.
Yeah.
This
Wow.
isn't fancy.
Well, this has been helpful. I'm going to put the link for those that are watching on TV. You can go to that link. Otherwise, I'll put it in the description section. Mark, I hope we get to talk again. I want to respect your time, and this has been great.
Catch back up. This is like the little intro.
Yep.
And go pull that little book up. And if you have trouble with obesity or type 2 diabetes, give a read, and maybe, there's no reason over the holiday, to eat the meat and the cheese and not the cookies. It's the most delicious food will be presented to you in the next couple days, even without the big family gathering. So maybe that's a good thing. You don't have grandma's cannolis, you can just, have some salami.
Great. Thank you so much, Mark, for your time.
No, thank you, Don, and have a great holiday.
Hey guys, thank you for watching Healthy Living. You're going to find a few links here I'd like you to click. One is to subscribe to this channel on YouTube. Also, you can learn more. There are some videos here you can see.